Good afternoon, everyone. Thank you for this opportunity to present our work on occult inguinal hernias. Okay, there we go. I have nothing to disclose. So I don't need to explain to the audience here, right? Inguinal hernia can be a well-known source of growing pain, and hidden or occult inguinal hernias, as we define it, are really symptomatic hernias that do not present with a bulge. And for some surgeons, no bulge means no hernia, and these patients are not offered a hernia repair, despite having very hernia-specific symptoms. On top of that, diagnosis can be very challenging, even with cross-sectional imaging studies. So our goal was to present the common findings of patients with occult inguinal hernias and share their outcomes after repair to provide insight into this special population. So to do this, we performed a retrospective review of a hernia database at a single institution, including 10 years of data, including all patients who had primary inguinal hernia repair. We included open, laparoscopic, or robotic approaches with or without mesh. The patient characteristics as well as outcomes were compared using Fisher's exact test, chi-squared, and Wilcoxon rank sum when appropriate. So how do we define occult inguinal hernia? So these are patients that came in, complained of growing pain, but had symptoms very suggestive of inguinal hernia, which means, typically activity-related pain, pain radiating to the inner thigh, testicle, to the back. They did not have any bulging on exam. However, oftentimes they will have some tenderness and fullness over the inguinal canal. A majority of the patient did end up getting some sort of imaging study, ultrasound, CT, or MRI that is consistent with the inguinal hernia, and were ultimately confirmed to have a hernia in the operating room. So here's our results. We had a total of 485 patients. 212 of them were considered to have occult inguinal hernias. Out of the patients with occult inguinal hernias, they were noted to be younger, more likely to be female, with a slightly higher BMI. However, there were no significant differences in terms of preoperative comorbidities or hernia-specific risk factors. In terms of their preoperative symptoms, we found that patients with occult inguinal hernias had more pain, had higher pain scores, and for longer periods of time compared to the non-occult group. And you see here, the duration of pain is 28 months. That's over 2 years of pain on average. On exam, patients with occult inguinal hernias were found to have more tenderness compared to the non-occult group, almost twice as much. And more importantly, these patients with occult inguinal hernias are more likely to be using pain medications, including opioids. 23% versus 8%, that's almost a 3-fold difference. So in terms of their operative characteristics, majority of the patients in both groups underwent minimally invasive inguinal hernia repair, and over 90% had a mesh repair. In terms of the specific types of hernias, patients with occult inguinal hernias were more likely to have femoral hernias and less likely to have direct hernia found at the time of the operation compared to the non-occult group. In terms of their postoperative outcomes, we noticed significant decrease and improvement in their pain score after hernia repair in both the occult and non-occult group. However, the occult group still had slightly higher pain scores compared to the non-occult group. Now, this is a statistically significant difference, but if you look at the pain score here, it's a very low score, so pain went from 2 to 1. So because of the low score, the true clinical significance of this is a little bit uncertain. And lastly, although the occult group of patients had slightly less symptom resolution compared to the non-occult group, 83% of the patients were essentially cured of their hernia-specific symptoms. Now, our studies is somewhat limited by the retrospective design, as well as us being a single specialized hernia center. Our research and interest in the past have potentially increased the proportion of patients that come to see us with occult inguinal hernias. So in conclusion, while some surgeons may hesitate recommending repair to patients with occult inguinal hernias because they don't have a bulge, our study challenges this perception by showing that discounting growing pain due to occult hernia can prolong patient suffering and may risk increased opioid use, especially in female patients, and potentially denying the 83% chance of cure of patients who are experiencing growing pain related to an occult inguinal hernia. So early diagnosis and operative intervention should really be considered in this subset of patients. Thank you. I'll take any questions.